Good afternoon, everybody. We're winding down the day, but I see there are several people still joining, so we'll give it another minute or so. Okay, there's still a few people joining, but just to try to keep us on track and on time, we'll go ahead and get started. Welcome everybody to PWSA USA's first Sleep Summit. We've had an amazing day so far. We've had 4 great presentations. We had Matt Horsnell from Trend. We had Dr. Ravana from Texas Children's, Dr. Singh from Maimonides Medical Center, and Dr. Shelton and Dr. Veach. So it's been a fantastic day so far. And we're so honored to have all of these experts with us today and sharing their expertise on sleep. We've talked a lot about, REM sleep, central and obstructive sleep apnea, daytime sleepiness, narcolepsy, cataplexy, just so much information today. And just a quick reminder that these sessions are recorded. They'll be available on our YouTube channel at the end of the week. They'll be available on our website, and we will try to send them out to everybody who registered as well. So you won't miss the information. You'll be able to go back and listen. As I know, there was a lot of information, and has been and will be a lot more information today. So thank you again to our sponsor, Harmony Biosciences, for making this Sleep Summit possible. It's been an invaluable resource to many, and I'm just very, very grateful to them and to all of our physicians and speakers today. So with that, I'm going to turn it over to Stacy Ward, our Director of Family Support. Stacy?
Thank you, Paige. Thank you, Dr. Dewis, for joining us today. Dr. Dewis is going to present on the presentations and management of sleep disorders and Prader-Willi syndrome. She is an associate professor of pediatrics and genetics at Children's Hospital, Colorado, at the University of Colorado. Dr. Dewis did her medical training at Johns Hopkins School of Medicine in Baltimore, and then completed a postdoctoral fellowship in the Johns Hopkins Department of Psychiatry and Behavioral Sciences. She is a board-certified pediatrician and medical geneticist who practices in the area of genetics and complex special care pediatrics, and primarily performs diagnostic workup and management for individuals with rare disorders focused on neurogenetic conditions and rare genetic conditions of obesity and metabolic conditions. She has focused her career on chromosome 15 disorders, including Angelman syndrome, duplication 15q, and Prader-Willi syndrome. She founded and built centers of excellence for Angelman, Prader-Willi syndrome, DUP15, and Pitt-Hopkins syndrome. Dr. Dewis's career has spanned translational, clinical, and bench research. She is passionate about establishing standards of care and personalized therapeutic interventions for individuals with neurodevelopmental disorders to improve quality of life and equity of care. She recently published guidelines on the diagnostic workup and management of sleep concerns for individuals with Prader-Willi syndrome. Dr. Dewis, thank you so much for taking your time out of clinic to be here with us today.
Absolutely. Thank you so much for having me and for such a kind introduction. So with that, I'll get started. And I'm hoping that some of the defining sleep disorders that's gone on during the day will be a nice segue into specifically talking about some of these concerns that Paige brought up in Prader-Willi syndrome. So we'll go ahead and get started. This is meant to be interactive, so please stop me with any questions, and also case-based, so meant to be very interactive. Perfect. Some disclosures: I do some speaking on rare genetic causes of obesity, and then was recently funded by PWSA USA to do some work on pharmacogenomics. So today I'm going to use some case-based studies to discuss presentations of sleep disorders in Prader-Willi syndrome. We'll consider the diagnostic evaluation and really focus on when you should be thinking about sleep disorders in PWS, and then talk about some strategies for management. So we'll start with a case. So this is a very common situation in our clinic here at Children's Hospital Colorado. So a 10-year-old male with Prader-Willi syndrome noted to fall asleep at school. So oftentimes we'll even get phone calls from the school or from parents saying they need us to interact with the school and educate them about PWS. And a lot of times if the child is awakened or even adult is awakened, they can be very irritable, escalate behavior. So that rapid escalation you may have heard about today from Dr. Singh talking about rapid escalation from A to Z, and very quick to get frustrated and angry in general, sometimes around food, but it could be anything and triggers can be unclear. And then parents report could sleep anywhere, especially on car rides. So I think anybody that is familiar with PWS would say that this is actually a very common presentation that we see in individuals with PWS, both from the standpoint of very quickly falling asleep in certain scenarios, such as in the car, but then also some of these behaviors that can rapidly escalate, sometimes around food, but like in this case, not always. And so this is a presentation of excessive daytime sleepiness that's very common in PWS. And excessive daytime sleepiness, which I'm sure you've heard this already today, but is decreased wakefulness with an increased percentage of sleep time and stage N3 sleep during the day and night. It may be a part of the initial clinical phenotype at birth when we see individuals with PWS who are excessively sleepy and often fall asleep during feeding. And that concept of thinking about excessive daytime sleepiness in Prader-Willi syndrome from the time of birth and as a part of PWS, I think is actually something that we're recognizing and putting together with this later excessive daytime sleepiness, that in the past we really haven't thought about in the newborn period how much disorders of sleep could play a role in some of the concerns we have, especially around feeding and wakefulness in infants. And in a study, 67% of adults with PWS reported EDS. So a majority of patients do report some experience of excessive daytime sleepiness. And the really big challenge with a lot of these sleep disorders is that it's hard to completely take obstructive sleep apnea out of the picture in many individuals, whether it be from the standpoint of compliance and consistent use of their CPAP therapy, or whether it be that even with CPAP, we still see some residual sleep apnea. And so with ineffective treatment of sleep apnea, some excessive daytime sleepiness is expected and is in part is a question we ask when we're thinking about sleep apnea. So this can be hard to officially diagnose, as well as some of the other diagnoses that I'm going to talk about today in PWS. And just one thing that's really important is it's not always straightforward what that presenting symptoms go along with a certain system or specific differential. And so when we're thinking about irritability and behavioral disturbance, it's really important to always be thinking about some of these sleep disorders that we're going to talk about, including excessive daytime sleepiness. So I really want to drive home this idea that excessive daytime sleepiness disrupts school performance and is associated with the irritability and behavioral disturbances that we often see in PWS. And like I said, it's not always one specific cause for some of these symptoms. It's usually multifactorial, meaning that for excessive daytime sleepiness, yes, there's underlying sleep disorder, but it may manifest as other symptoms. And in this case, we will often see psychiatric symptoms like ADHD, for example, or rapid escalation of mood, as examples that we often do see in PWS. And this diagram I find very helpful. This is not developed specifically with respect to PWS, but thinking about excessive daytime sleepiness and what the causes are, if we go through that differential, we think about inefficient sleep. So poor sleep hygiene, not having a good routine in terms of sleep, medical conditions, psychological disorders, as we've talked about, including depression, something to think about, an effective pharmacological intervention, circadian rhythm disturbances, and then causes of disturbed sleep, such as environmental conditions, medical conditions, OSA, as I mentioned, movement disorder, parasomnias, and behavioral disorders would fall under this. And one of the things we see commonly in PWS is these perseverative behaviors, or one thought kind of continuously, repetitively invading their thoughts. Anxiety can play a role in disturbed sleep as well. And then increased sleep drive. And so narcolepsy can fall into this category, which is another thing that we're going to talk about to cause this excessive daytime sleepiness. So even in individuals with established diagnoses of OSA, when we think about that apnea hypopnea index that hopefully you've heard quite a bit about today, there is this out of proportion finding of the excessive daytime sleepiness to what we would expect for a level of OSA. And that's really an important clinical feature that we see commonly in PWS that I think we really need to start considering. Because if we think about standard of care, it's always, well, we have to get OSA under control to think about some of these other diagnoses. And I want to emphasize that you can look at individuals with PWS who even have mild sleep apnea, and they're excessively sleepy during the day, getting in the way of their daily activities. In addition, even if that's not occurring, there may be some other signs that excessive daytime sleepiness is there consistently, such as with irritability or behavioral concerns. So that's something that I think is really important to consider. But when we think about excessive daytime sleepiness and our standard of care workup, we will often recommend a sleep study, particularly in PWS where obstructive sleep apnea is so common. And that starts with having an inpatient sleep study. In pediatrics where we're more likely to do that, although there are emerging home sleep studies that could be considered in especially older individuals. And then we will often recommend doing something called a multiple sleep latency test. So what this looks like is you come in for your polysomnography or sleep study, and then in the morning, when you wake up, and oftentimes we will wake up the individual at 8 a.m. to do these tests here. And what you see is that they have you with the patient awake, they apply the electrodes, and then they look at how long it basically takes you to fall asleep in different epochs, looking at how quickly an individual falls asleep. And if you meet a certain threshold, you could meet the criteria for excessive daytime sleepiness. Narcolepsy is also looked at in this same way. So when we think about excessive daytime sleepiness in PWS, there's been some medical literature considering how we treat these individuals. And again, because it can be so pervasive in terms of how these symptoms manifest, and it greatly impacts quality of life for these individuals. So one of the things we consider is modafinil, which there was a clinical case-based study, so not a randomized clinical trial, but a study of modafinil in 10 patients with PWS from 8 to 21 years of age that showed that it effectively decreased sleepiness. There's one case study of clomipramine. This is generally not a drug that we recommend, but there was a case study in reviewing the medical literature that showed that in an 11-year-old boy treated with this, that there was improvement both in nocturnal hypoxemia and excessive daytime sleepiness. And then tryptophan has been studied in a single case study, showed that it helped with excessive daytime sleepiness. And then there's been emerging literature on a drug that many of you probably have heard of called Petolescent, that it recently completed a clinical trial with some individuals on an open label extension at this point, showing that there may be some improvement in sleepiness and also cognitive function in some cases reported in the medical literature. And there's been now these two references, but then there's also now been actually from the group here a single case report of an adolescent using Petolescent and having some improvement in behaviors and mental health concerns as well. So in our clinic, just to give you a sense of our experience, we really do think about how does the apnea hypopnea index relate to how much excessive daytime sleepiness that we see. And I will say in our clinic visits, which are about 4 hours long in the multidisciplinary clinic, we will often see kids fall asleep in that clinic. And so that's often helpful at giving us a good idea of at least excessive daytime sleepiness. And so we will often treat even if there's still some residual OSA, if we see that the EDS is likely to be out of proportion to the amount of OSA that we see. So another case here is an 8-year-old with recent excessive weight gain who presents with irritability, excessive sleepiness, increased food seeking, including awakening and foraging for food at night, worsening school performance and headaches. Parents have recently noted more snoring, especially when ill. And if you look at this growth curve, you can see that there's been this transition over time, crossing multiple percentiles to where the individual is now. And anybody want to give any thoughts on this case? Questions from the last case?
I'm not seeing any questions yet.
Okay, so this is something that you've probably heard a lot about today, which is obstructive sleep apnea. Obstructive sleep apnea is present in almost all of the individuals that we see with PWS. In the medical literature, it's more than 80% of individuals with PWS that have sleep disordered breathing, and a large part of that is OSA. And there are certain things that we really think about in terms of when do we get sleep studies. I see something in the chat. Is the use of modafinil contraindicated in persons being treated with psychotropic medication? So it depends on which medications. One of the things that we see with modafinil is that there can be some side effects. The one we always worry about is Stevens-Johnson syndrome, so a rash that can progress very quickly and include the mucous membranes. But the other thing we worry about is arrhythmias. And so what we will often do, especially if individuals are on multiple medications such as SSRIs or selective serotonin reuptake inhibitors, is that we will get EKGs, but it's not a contraindication. It does require some monitoring, and sometimes it's helpful to talk to the pharmacist about what drug interactions might be there, but it's not contraindicated. Good question. So for obstructive sleep apnea, when we're thinking about when should we be checking sleep studies, it's really important to think about that rapid weight gain that I showed for the case. because that is an indication in and of itself to get a sleep study and rule out some worsening obstructive sleep apnea. In the percentile of BMI for the individual's age is associated with more severe hypoxemia during sleep and more sleep disruptions in general. So one of the things that I often will tell families if we see rapid weight gain is that we do need an updated sleep study. And it's really important to recognize how much obstructive sleep apnea can affect the individual's quality of life. And this includes learning at school, paying attention. Untreated sleep apnea has also been associated with more severely delayed milestones, developmental milestones. So that's something to keep in mind as well, particularly if you have an individual that you're following that's not making the progress that you would expect for PWS, making sure that you're thinking about that. And as well as repetitive behaviors and perseveration and worsening impulsivity can go along with worsening OSA as well. And so the other indication to get a sleep study that we utilize in clinic as individuals get older is change in behavior. Any behavioral changes we're thinking about, could there be some worsening of obstructive sleep apnea in individuals with PWS? So diagnostic workup, again, familiar with what we were gone through. Polysomnography, which is an overnight inpatient sleep study in pediatrics, is the gold standard for how we would diagnose obstructive sleep apnea. And then there's some guidelines that came out last year from one of the otolaryngology societies that individuals who are do not yet have tonsils and adenoids who have obstructive sleep apnea should undergo drug-induced sleep endoscopy to try to diagnose the cause and potentially offer surgical interventions. And so this is something that in our infants that we see who undergo sleep study, who have severe obstructive sleep apnea in particular, we will send them to ENT to get what's called a DISE or drug-induced sleep endoscopy. Another question here, looking at modafinil, what's the upper end of the dose? And at what point should we be considering a different medication if modafinil is having less of an effect, regardless of the child consistently using their CPAP? I honestly, so when I'm thinking about modafinil, I'll start, depending on the age, if they're pretty young, I'll start as low as 50 milligrams. We started as young as 6, I would say, is the youngest that I've used it. And then titrate up. In younger kids, I may use a cutoff of 100 and then give another 50 milligrams around lunchtime, actually. And then in older kids, we'll go up to 200, but I don't push it above 200. And I call it failure if 200 is not helping the individual. I usually go down to age 6, is the youngest age that I've treated someone with excessive daytime sleep. And I will say that's a situation where it's an individual who's so irritable and having lots of outbursts. And sometimes thinking about it from the sleep perspective is much more effective than thinking about it from an anxiety or other behavioral perspective. So I'll go down to age 6. Okay. So treatment of OSA, I think you probably have heard about this today too, but depending on the age of the patient, especially referral to ENT, there may be surgical intervention that could make a big difference. Like I said, drug-induced sleep endoscopy in an individual who doesn't yet have tonsils and adenoids. But if there are tonsils and adenoids, even just an adenoidectomy sometimes can make a big difference in some of the kids that we see. So sending them for that evaluation. Oxygen is sometimes used particularly in younger individuals, but also we have used it in some of the individuals we follow who really cannot tolerate use of PAP therapy. CPAP or BiPAP would be the gold standard. We often will recommend behavioral therapy if the individual just can't tolerate the CPAP therapy or BiPAP therapy. And we have a fantastic team here that is a psychologist here who works with people to desensitize for use of PAP therapy. Mild OSA, there was a clinical trial that looked at, not specific to PWS, but a clinical trial in pediatrics that looked at use of Flonase and Singulair and showed that there was improvement in mild OSA with this treatment. And we often will do this actually without Singulair, but we have some individuals who are on both. And then we are looking more at Optiflow nasal high flow therapy in individuals who fail PAP therapy. And this is flow-based control, so slightly different in its nasal prongs that go in the nose. And so we have had, it's called Airvo. We have had some individuals who respond better to that type of therapy. And so that is also an option if someone fails PAP therapy that we've been using more and more. No talk about OSA and PWS would be complete without talking about growth hormone. Current recommendations are to absolutely monitor for obstructive sleep apnea in individuals who are on growth hormone. The FDA recommends that you get a pre-sleep study before putting an individual on growth hormone, and then a post approximately 6 to 10 weeks after initiating growth hormone. What we really have been doing, since a lot of individuals are often in the NICU, is to look at telemetry in the NICU. And if telemetry is reassuring, then to skip the initial sleep study and go ahead and not delay patients getting on to growth hormone right away. And then we'll just do that later study 6 to 10 weeks post initiation. Part of the challenge with getting kids on growth hormone as young as possible, which would be our recommendation, is that it's hard in the really little kids, less than 4 months, especially, to get a sleep study. And we don't want that to delay getting started. So we have been doing growth hormone therapy without that initial study. Findings of worsening obstructive sleep apnea should expedite evaluation of the individual. We've had some families actually notice changes in sleep after starting growth hormone, and we have recommended that this not stop or delay growth hormone, but that it result in immediate assessment. And this is highly variable. So this is what we do at our center. I don't know that a lot of times when we're having conversations about this, there isn't clear medical literature, and we're hoping that this will change with more collaborations between centers going forward. But there isn't one clear way to do this. I'm just talking about what we do at our center. And then any changes like we've talked about, worsening excessive daytime sleepiness, snoring, witness apnea, which could be like a child snoring and then having a pause in their breathing, or coughing, seeing a pause and then a cough or a gasp would be concerning. Crossing percentiles in weight, change in behavior should all prompt a referral for polysomnography. And then in our consensus guideline that was published, we recommended that at age 3 and at the time of puberty that you go ahead and just do a sleep study. Okay, case 3. Let me see if there looks like there might be a question. So so this is a question about central sleep apnea, and I am going to talk about central sleep apnea shortly. So we can leave this question, and then if it doesn't get answered, I'll try to answer it while I'm talking, but if it doesn't get answered, let me know. Okay, so infant in the NICU, having apneic events. So this would be like on telemetry. We don't generally get sleep studies in the NICU, at least here. And then having a drop in heart rate or bradycardia, low muscle tone, poor interest in feeding. Testing for PWS is pending in this case, but suspected. And this is can be central sleep apnea. It can also be obstructive sleep apnea, but in this case, it was central sleep apnea, in which this is more geared towards adults with central sleep apnea, which can be related to like heart failure. But I thought this was actually a really helpful slide in understanding symptoms. What happens in central sleep apnea is that the respiratory center in the brain that tells your body to breathe does not work properly and does not tell you to breathe properly. And so you have these events where you stop breathing that's mediated from that central respiratory center. And that's why it's called central sleep apnea. And it is pretty rare outside of the infant period and the neonatal period to see a lot of central sleep apnea in PWS, unless there's other triggers as they get older, such as worsening obesity and heart strain from obesity. But we can see it. And so thinking about some of these symptoms, really a lot of these symptoms go along with just poor, sleep disorders in general, such as poor memory and concentration. But headaches, early morning headaches can be a sign. So that's something to kind of think about as well. And then I talked about this a little bit, but what do these look like on polysomnography, which would also be the gold standard for how we would diagnose central sleep apnea. So in obstructive sleep apnea, no airflow with respiratory effort. What this means is that there's some obstruction within the within the airway. So could be that oftentimes in individuals who are obese or low muscle tone could be the tongue flopping back. And that's why with PAP therapy, we force airway pressure to try to keep that airway open. In central sleep apnea, there's no airflow and no respiratory effort. And so those look different when we're looking at the polysomnography. So we know whether it's an obstruction to airflow or whether there's no respiratory effort that's causing that lack of airflow. And you can have mixed, and we see mixed frequently in PWS, especially in that infant period, where you can have no airflow and no respiratory effort. So when we're thinking about screening and treatment of central sleep apnea, there is some connection with central adrenal insufficiency that's reported in the medical literature. So we always mention considering ruling that out. Continued monitoring with frequent polysomnography approximately every 6 months in individuals who have this diagnosis can be helpful just to make sure that you're not missing central sleep apnea that would need treatment. And in the infant period, we generally use supplemental oxygen, but then for older individuals, we'll use positive airway pressure for treatment of central sleep apnea. And so coming back to this question, we were always told that we should not put our child with central and I think this central and obstructive apnea on CPAP because they were concerned this would make his muscles lazy and make him dependent on it. We were told it was better to force his system to work. Can you comment on this? I mean, if there are sleep specialists in the session as well, please feel free to chime in as well. But my general feeling about this, and I think our sleep specialist would say it's important to make sure you treat these things effectively because they can be quite dangerous and like we're talking about can contribute to a lot of symptoms and concerns during the day that can affect quality of life. So my general thought would be it's really important to put the individual, depending on their age, on CPAP because it will force that airway open. It'll force air into the airway if there's a central event, and we wouldn't want anything long-term to result from central sleep apnea in the individual with PWS. Does anybody else want to comment on that? And I'm not sure if we have any sleep specialists on, but that would be my general thought about that, is that it's important that actually the individual should be on CPAP therapy. Okay. Case 4, so a 6-year-old with PWS presents with a history of concern for seizures, ruled out with an EEG in the past. So they looked to see if the individual's having seizures by putting some electrodes on their head while they were having the concerning behavior or concerning movements, and didn't see anything. But it's described as loss of tone during eating. More recently, she's been falling asleep sometimes mid-sentence. The school is concerned about a change in her performance at school recently. If she's awakened from sleep at school, she gets very angry and emotional. After seeming to regain her energy, she falls immediately back asleep after having a behavioral outburst. A recent sleep study shows mild OSA for which ENT recommended Flonase. Her level of sleepiness is out of proportion to her mild OSA. Parents come to clinic concerned about regression due to seizures. This has actually been relatively common, I think, recently. And so this should make you think about narcolepsy and cataplexy. And this is, I know this has become more and more clearly a part of PWS, although with some perhaps milder or different features than we would think about for typical narcolepsy and cataplexy. So for narcolepsy, this is just in general, this is not specific to PWS. You can have profound facial hypotonia and some motor tics associated with it, which we sometimes see in PWS. Lots of automatic behaviors, so that's repetitive and common behaviors at night, disruptive nighttime sleep. Obesity is actually more common in individuals with narcolepsy as well, and attention deficit disorder or behavioral concerns. Cataplexy, which is basically traditionally thought of as an emotional trigger that then causes the individual to immediately fall asleep. Traditionally, people might think about laughing. So it can resemble seizures. And one of the things we found in a recent publication from the Global Registry was that individuals with PWS, about 13% have seizures. So this can be really important to rule out. There's usually loss of tone or complex hyperkinetic movements associated with these episodes. Facially, there can be involvement with active movement of the tongue and perioral muscles, which is why some these can look like seizure events. And there can be cataplexy without a clear emotional trigger as well. And one of the things that's been really interesting is that in individuals with PWS, when they start eating solids, a lot of times we'll see these episodes where they're eating and they're kind of sundowning or falling asleep and their heads dropping while they're eating. And we actually think that that is an example of cataplectic episodes in individuals with PWS that could start from a very young age. And so sometimes later, when I'm evaluating a child who has excessive irritability during the day, behavioral outbursts, and I'm thinking about, honestly, excessive daytime sleepiness and narcolepsy, a lot of times I think about those together in this population. I'll ask if family ever noticed some of those episodes of kind of head drops or when kids were eating. And then this is our consensus statement on the workup for narcolepsy and cataplexy, which I think is helpful. It gets back to the importance of recognizing that effective and complete treatment of OSA is very challenging in PWS, and that should not delay diagnosis of narcolepsy and cataplexy because of the opportunities to treat and change quality of life in these individuals. So it should be considered, particularly when it's felt to be that their excessive daytime sleepiness is out of proportion to what you would think for their untreated OSA. So treatment of narcolepsy and PWS is not too unlike some of the other things that I've discussed. These are some of the treatments that are actually used for narcolepsy in a guideline statement from the professional sleep organizations. And the traditional treatment has been amphetamines, methylphenidate, so stimulants have been a first-line treatment for narcolepsy and have been used in PWS. I don't love using them in PWS because a lot of times they can make skin picking or anxiety worse. And so I'm very cognizant of that. Modafinil is another one that we've already talked about, that there's some medical literature that it impacts sleepiness and PWS. And then specifically for cataplexy, the standard of treatment would be those SSRIs or tricyclic antidepressants. These we have to be cautious with because they can be what we call activating in PWS, meaning that they can affect the balance of hormones in the brain or neurotransmitters and actually cause some of those aggressive behaviors or sensationalization or change how the thought process of the individual, which can be dangerous in PWS. So we always kind of get a little bit more history about the individual and think about whether that's really the next best step. Sodium oxybate is being used as a drug of choice for narcolepsy. This is the same active ingredient as drugs that have been like date rape drugs. And it's been extremely effective in individuals who have narcolepsy type 1. There are some important concerns about the effect on respiration and respiratory depression, which we know that the ventilatory response in PWS is not typical. And so I don't know of anyone who's using this in PWS or would consider using this until there's a more clear clinical trial to say whether it would be safe. And then Petolescent is one that we actually are using and prescribing off-label all the time now for PWS in adolescents. It's approved in the United States for 18 and up for narcolepsy with cataplexy, and it's been something that we fight with insurance companies and try to get in individuals with PWS. I will say this is not one that I'm getting down as young as 6. It's more adolescents that we're able to show they have narcolepsy and get them on the treatment. So just a few other things, and then I want to hopefully have times for questions. Other things to just be aware of in PWS is that we definitely see chronic insomnia, so individuals up at night, and there are certain things you would consider, food seeking, individuals getting up at night and foraging for food or thinking about foraging for food, behavioral concerns, anxiety, perseverative behaviors that could impact sleep. We often recommend referral to a sleep specialist and considering behavioral therapy. And then the other thing that we've seen be extremely helpful, particularly if there is foraging for food at night, is increasing food security, locking things, making sure that the individual with PWS knows their lock and they can't get to them, because that decreases their overall anxiety and has been really helpful in terms of just extinguishing the behavior. And then Restless Leg Syndrome. So there's a recent review that was published on iron supplementation, improving restlessness and restless leg syndrome in comparison to placebo. And so when we see restless sleep, we will often check a ferritin level, which is our body's stores of iron. We always check this with a inflammatory marker, because when your body is inflamed, your ferritin also increases. So we want to make sure that we're getting a clear picture of what the iron stores are doing. And then even when the iron level is not low, there has been shown to be benefit in treating this. And so our cutoff goal for when individuals have restless leg or restless sleep is actually 50, which is quite a bit above the lower limit of normal for ferritin. So we will often put individuals on iron therapy. Really important, though, to know that iron therapy definitely worsens constipation. So which we see frequently in PWS. So you want to be thinking about how are you going to mitigate the constipation, and then you want to monitor the ferritin to make sure you're dosing appropriately and that it's coming up effectively. And then ingestion of iron can be quite dangerous. So you want to make sure that this is locked in a cabinet where the individual can't get to it. And so I just want to come back to something so important when we're talking about presentations of sleep disorders in PWS. It can affect so many different body systems, and a lot of the things that we see on the day-to-day with individuals with PWS, such as the perseverative behaviors, the irritability, the anxiety, can just be related to ineffective sleep, can be related to excessive daytime sleepiness, can be related to a narcolepsy-like clinical features in PWS. And that's a very different treatment paradigm that we would start to think about in terms of treating this effectively. It can also really impact their processing speed and how well they're doing at school. Also motor and balance concerns, lots of effect on physical health. Food seeking can be worse in these cases as well. And then activities of daily living, such as school performance, fatigue, can certainly contribute to irritability, and then the stamina. So to be able to participate in Special Olympics or activities can greatly be affected by sleep disorders. And then this was our consensus on what should we be thinking about in individuals with PWS. Growth hormone is obviously a key to treatment of PWS, and all individuals with PWS should be on growth hormone. But how do we think about growth hormone in individuals with OSA, making sure that we're monitoring this and that we're not missing anything. But as I said before, really important to kind of think about what's available in your region, whether it makes sense to delay growth hormone therapy. And in our opinion, we don't delay growth hormone therapy to wait for sleep studies. Annual evaluation in PWS, thinking about some of these other presentations of sleep disorders and really adding to your differential sleep disorders as a cause for some presentations in PWS is really important. And patients with PWS should have access to sleep specialists and on their multidisciplinary team. That's really, really important. We have several specialists in our clinic who focus on sleep, both from an ENT standpoint and a pulmonary standpoint. And then when we're thinking about getting repeat sleep studies, lots of different indications for this: change in weight across 1 to 2 percentiles, or just rapid weight gain in general, change in school performance, new onset of attention concerns, worsening excessive daytime sleepiness, more irritability or changes in behavior, effect on school performance or development. All should result in a comprehensive sleep evaluation. Often we'll recommend polysomnography, which is an inpatient sleep study, which is our gold standard for diagnosing obstructive sleep apnea and sleep disorders, and then followed by an MSLT in the morning, if you can do it, to really understand if there's other aspects beyond what we would have considered just for obstructive sleep apnea, especially. And then treatment really should be considered for a lot of these indications. And sometimes it's just reasonable to trial a medication that's targeting sleep when you're having a lot of, for example, behavioral concerns, to see how effective the treatment is. And so we have a great team here. We have Norm Friedman, who is an ENT trained in sleep, and then Dr. Stephen Hawkins also is a pulmonologist trained in sleep. We also have a fantastic NP, Heather Moore, who works closely with us. So we have a really big team here that I work closely with. And with that, I'll take any questions.
All right. Thank you, Dr. Dewis.
Yeah.
Great presentation. And there are a couple more questions. I know you can probably see them, but one of them is any recommendation for an older PWS individual who has severe sleep apnea, won't tolerate a CPAP. He's 41, recommended to go to PWS clinic at Children's Hospital. His PWS psychologist is Todd. So let you answer that.
Yeah, so for one thing, I would ensure that there's been a thorough workup for some of the complications of untreated sleep apnea. So making sure you're getting an echo of the heart, making sure you're looking at pulmonary function, all would be really important. And the other thing I would recommend is seeing ENT and seeing if there's any surgical intervention that they could recommend for the sleep apnea that might provide some benefit beyond what's without using the CPAP. Sometimes we've had some success with that. And then it would be helpful to know weight-wise whether this individual is overweight, because just weight loss in general can make a huge difference for sleep apnea that's not successfully treated.
Thank you. There's one here that says our 4-year-old son with PWS has frequent cataplexy leading to falls, as well as other symptoms of narcolepsy, including EDS. Any treatment options at his age that are safe and effective? Petolescent, and are SSRIs safe for a 4-year-old?
Yeah, so there is some research on some SSRIs in down to very young ages. And so that probably, if cataplexy is present, that might be where I'd start and look at SSRIs available in liquid formulation. So Celexa is one of them that we will often try. And then, the youngest I've treated, I think, is maybe 5 or 6 with some of these agents. But I think it's worth having a conversation of risks and benefits and thinking about additional considerations for treatment.
And then I'm not sure if this is a question or just a statement. Redner recommended more genetic testing to further study deletion in the 15th chromosome.
I believe that's a follow-up from the last question.
The previous one that they asked.
Yeah, with Todd was psychiatrist or psychologist.
Gotcha. I'm not sure if so I think I would need more information. It sounds like has the individual been diagnosed with PWS, and it would just be to understand the specific genetic subtype of PWS in terms of additional genetic workup. But happy to talk more offline, particularly if you're in Colorado. We do have we're able to see adults in our, in particular in our, what we're calling our mini clinic, which doesn't have all of our specialists, but we could at least see you and get you started if you're local. So happy to talk more about how we could help.
That's very nice. Thank you. This person asks, has the implant Inspire been looked at in older PWS individuals at all?
That's a great question. Not that I know of. I don't think that there's any clear evidence for specifically PWS.
All right. And then the next question is, will we ever be able to begin growth hormone in the NICU to help ensure, strengthen breathing and feeding right out the gate? Do you believe this would be the standard of care, or is waiting best?
That is the standard of care. And I think one of the challenge, and I get a lot of consults, like outside consults, people find my name and email me or call me asking me this question. And I would say this is the standard of care. It would be lovely if we could do some more studies and look at individuals who are started on growth hormone in the NICU and systematically study whether we see a change in muscle tone or we see improvement in feeding. And I think that study needs to be done to convince people across the world that this is the standard of care. But we really strongly advocate that individuals get started on growth hormone in the NICU. The challenge is that most hospital pharmacies don't carry inpatient growth hormone. And so what you have to do is the endocrinologist has to go through your insurance and prescribe it outpatient. Parents have to pick it up and then bring it to the NICU to administer it. But that said, we have done that. And I strongly recommend this become the standard of care. And maybe it takes publishing something to say that more clearly, but I think it's really important.
The next question is actually for us. Does PWSA have a list of sleep specialists who treat adults? My daughter's 38. We're willing to pay and travel to see someone. So to answer your question, Peggy, we do have the healthcare database on our website. If we are aware of somebody who is treating adults for sleep issues, it is on there. However, it is one of those areas that we're not aware of a lot of people. So we do need to expand that. So I would recommend, for our participants who are watching, if you see a sleep doctor, please send us their information so that we can add to our database and get that information out to everybody.
All right. Next question. My daughter's 3 years old. She had mild obstructive sleep apnea when she was an infant, but got better with growth hormone therapy. Will she have sleep problems as she grows?
Not necessarily, but it is very common. I think almost 70% of individuals with PWS have neurological disorders of sleep or sleep apnea, so respiratory disorders of sleep. So it is something that will continue to need to be monitored. I think the things that you can do to prevent this as much as possible is monitor weight and making sure that you're managing weight with good food security in all of our environments. And that can certainly help tremendously, but it's still possible that your child could develop sleep disorders, and so it's just something that needs to be monitored and closely.
Mm-hmm. And the last question I see here is, I have a 26-year-old with mild obstructive sleep apnea. He's 6'4" and weighs 180 pounds. He has restless leg syndrome, which disrupts his sleep as well. We had his ferritin checked and it's lower as well. Do you find iron infusions as opposed to supplements being helpful?
So iron infusions do have some risks. Like, for example, you can have a severe allergic reaction to iron infusions, but for some individuals, it's extremely helpful, especially if they can't tolerate iron because of the side effects like constipation. And so that's worth having a conversation with your provider if oral iron therapy has not been effective. The only other thing I'll say is for mild obstructive sleep apnea, trying Flonase and plus or minus Singulair or something called Montelukast could be helpful, and you could see if there's a benefit to that as well.
Great. Let's see. Ben has a follow-up question about his 4-year-old son. Our neurologist sleep specialist prescribed Petolescent for his cataplexy, but insurance won't cover it. Any suggestions on getting it covered or buying it affordably?
Great question. This is something that every time you try to prescribe Petolescent, you have to go through a prior authorization process. I haven't had it covered right off for any patient. The most important thing is to make sure that you have the data and that your child is being prescribed it by a sleep specialist. So if you have a PSG, so an overnight sleep study plus an MSLT consistent with narcolepsy, and you have a clinical features associated with cataplexy, you have to use that diagnostic code. The diagnostic code that the provider uses has to be narcolepsy plus or minus cataplexy. So if someone's trying to get it just for excessive daytime sleepiness or for PWS, it's not going to work. The other thing that we've done, since we always have to go through that PA process for the patient, is to provide some education to the insurance company about Dr. Pullen's papers are often sent to the insurance company from our center. 4 is really hard because it's so much younger than what the drug is approved for. But that said, it's still worth trying, and making sure you educate the insurance company. And if it goes to peer-to-peer, which it often will, then making sure your provider kind of, has this information in front of them to share the benefits specifically for PWS.
Great. I'm not seeing any additional questions right now. So I know it's been a long day, but thank you so much for your presentation. Phenomenal. Just like we said, I think we could listen to this for another hour. So thank you for your time today, and appreciate everybody that's here and attending. And we have one more session today. So thank you, and hope to see everybody in about 30 minutes.
Sounds good. Thank you all.
Thanks so
And
much.
don't hesitate to reach out if I can answer any additional questions.
Thank you.
Appreciate that. Thank you.
Bye,
All
everyone.
right, thanks. Bye.